Okay, good morning. I'm so happy to be here. Interesting, it's been full of webinars. I think this is our fourth webinar this month, and it's no wonder it's our fourth webinar instead of one or two. This month is the month we are celebrating older persons. This is the IGOP month, International Day of the Older Person. So you're all welcome. And I can see new faces, I can see new people. Thanks for clocking in. And it promises to be a sunny day. Welcome again. This morning, just before I go to the meat of the day or what we're going to be talking about, I would like somebody to you. He happens to be the president of the Coalition of Societies for the Rights of Older Persons. And he is also, that has kept us going. He's been a fantastic leader, and he's led us well. He's made sure that everybody is up and doing for the past. I'm so glad to introduce to you my president, Senator Eze Ajoku, the president of the Coalition of Societies for the Rights. A brief word this morning. Thank you. Sir, you may unmute. You're on the floor.
Good morning, everybody. It's my pleasure once again to welcome us to this fourth webinar marking the International Day for Older Persons as established by the United Nations. For us in COSROPIN, we celebrate the month of October, starting from the 1st. And I'm glad that some of our coordinators and senators and some members in the local governments are carrying out different activities to mark this period. For us, it's been very interesting. It's been a month full of activities, and we're very happy. And it's also a month when the efforts of COSROPIN has been recognized by government by conferring on me as your president as the officer of the Federal Republic, OFR, for the work we are doing in COSROPIN. So it's a wonderful month. We have had this month seminars on topics that affect our members, the older community. We have done a first week a webinar on world mental. We have done a webinar on aging with better sight, because as an older person, you need your eyes intact. We've also done last week training for our members, NGO financing and project development. And today we're looking at the topic stroke in the elderly. During the month, we have played golf for the elderly, veteran golf at the IBB, where we partnered with them. We have also played football match between the older persons and some youths of a particular denomination. Tomorrow, we are having the Graceful Aging Fellowship end of month program, where they will be looking at how not to grow old, what you need to do so that as you will age with grace. And later, from 12 o'clock, the same tomorrow, we'll be having a hangout with the Mabushi community, the Mabushi village community. We were there on Tuesday to do community engagement with them, agree with them the format of to load in wherever they benefits from that. Our lecturer is going to do a very good job. I've seen him on the platform, and I want to Kumbet. Want to thank you for accepting to speak to us on this all-important topic that affects a lot of older persons. Stroke has become an issue with older persons, and those of us who are over 70 know that we are always concerned about the issues of stroke, which could be a function of many things. Some of us are diabetic, hypertensive, and some of us have other issues that can expose us to this important topic we're treating today. So I want to welcome all our members nationally and those who are at this time on this webinar to listen to our able speaker. We're not too many right now. We're still about 16, and I look forward to others joining us very soon. So thank you for joining, and welcome to our
It's like network is playing some tricks here.
No. Go ahead.
Okay, thank you very much.
I have finished.
Okay, thank you so much, Senator S. Ajoko, OFR. We're grateful for always making out time to grace these occasions, even though sometimes it's so tasking. Sometimes you need to come out of some meeting, or sometimes you need to postpone a meeting just to make sure you are one of us in these webinars. So very, very grateful for your encouragement, and may God continue to keep you for us in Jesus' name. All right, so this morning we are talking about drug addiction and substance abuse. We're talking about World Stroke Day that's going to happen tomorrow. We're going to be talking about World Stroke Day that will be happening tomorrow. And but because of our activities, like the president explained, we had to postpone or bring forward the events to today. We all know that stroke is very recurrent on the older persons, and we all know that stroke is something that is very recurrent in older persons, and I'm sure that is one of the reasons that that's one of the reasons that is being emphasized. We also know that stroke is something that comes upon people suddenly. Some people call it the silent killer. And so we of COSROPIN make sure that we partake of this World Stroke Day, and that you will be fully informed. Just hold on. I don't have any paper. Just hold on, please. Hello? Just hold on, please. The paper you people gave me here, where is it? What is happening this morning? What is this? Okay, good morning. I'm so sorry. A lot of technical issues happening here this morning. And this morning, we want to talk about World Stroke Day. And it's usually observed, like I told you, on the 29th, which is tomorrow. And just to underscore how serious this is, and because it is of high risk, especially in the older persons. On this day, organizations around the world have facilitated events and emphasizing education, testing, and initiatives to improve the damaging effect of stroke worldwide. And so this morning, this will be welcoming Dr. Kumbet John Sonny. His titles are plenty of MBBS, BGDE, FMC, FM, BCGM, PhD, that is in, he is a consultant, family physician, a geriatrician. He works with Grace Nursing Care Center as a geriatrician consultant, and he also works with Federal Medical Center, KEFI, and many other hospitals in Jos and in Abuja. You're very welcome, doctor. We're so glad you're here. Thank you for your patience, and please take us on this journey. You may unmute your mic, please. Thank you.
Can you hear me?
Yes, we can. Yes, we can.
I want to specially congratulate our leader, the senator, for the conferment that was done by the Federal Republic of Nigeria for the work that he is doing. Please keep on doing the work. Congratulations, and congratulations to every stakeholder that have made it easy for all the elderly persons to have a smooth sail in Nigeria. Thank you for the privilege. I gave my slides to your technical clue for them to help me share. I don't know. Can we start sharing the slides so that we'll go on, we'll start discussing the topic? Hello? Hello?
Yes,
Yes,
I'm trying to share the slide.
Okay, thank you very much. So like we all know, stroke is actually a very, very important topic to talk about in the elderly. And just for this week, I saw like 3 patients that have that stroke. One of the patients that came to me this month, the day before yesterday, was in acute phase. In short, he just had the stroke 2 days ago, and everybody was confused in the family, and they had to rush him to the hospital, and they stay in a remote village down here in Nasarawa State, and moving him was a difficult time. In short, the first thing that happened was they started saying it's his enemies that were attacking him, took him to a spiritualist, trying to see how he can get back to his feet again. But that was not possible. They had to come to the hospital. And you could see the whole family, the wife worried, his children worried. This is a very, very agile person that interacts with people, is a source of help to a lot of people. And the whole thing got the whole family confused, and even the community. So we have plenty reasons, examples also to talk about. It's actually not something that one should think of having in a family or even for himself. And by the special grace of God, we will do justice, we will learn as much as we can. I would like you also to jot down questions. I don't intend to stay long. The most important thing is that we have something to go and share and to also learn. We jot down our questions, and during the Q&A sessions, we're going to deal with this. Thank you.
What's happening?
The PowerPoint presentation. Showing there.
Please, just a minute, we're working on it.
No problem. I'm trying to see if I can share from here too.
Doctor, I think you can go on now.
Okay, it's me that shared on mine. Can you see my slide?
Yes, we can, yes.
Okay, fine.
It's your stuff.
Okay.
Yes.
So I'm going actually to use this outline. We're going to define what stroke is. We're going to briefly talk about classifications. We want to see the burden of this stroke in the world, in Africa, and also our environment, Nigeria. We'll talk about a brief historical background of what stroke is. We talked about other terminologies. We talked about pathogenesis. Pathogenesis is, how the disease starts from the risk factor and how it affects the individual that has that. We'll talk about the risk factors. What are those things that prone one to have stroke? Then we'll briefly talk about the management. Then we'll go into Q&A question session. Hello, can you see my slides? Hello, everyone.
Yes, we can.
Okay. Stroke
Yes,
is a rapidly developing focal or global neurological deficit lasting longer than 24 hours, leading to death, and which is of no other etiology. Etiology means of no other cause other than vascular. Forget the medical terms. I understand some of us are not into the medicine. Let me break it down so that we'll go along. Now, what do we mean by focal or global neurological deficit? If you're talking about neurological deficit, it's something that has to do with the nerve or brain in the body. When you have, every part of our body, it has a representation in our brain. So pertaining or depending on what area of the brain that is affected, there is a manifestation in one part of the body. So neurological deficit means, okay, the way you walk, the way how strong, for instance, your hand is not as strong as it used to be. It becomes weak, or what people call paralysis. So that is neurological deficit. So if it's focal, when this stroke is occurring in a one position in part of the brain, then we call that focal. Now it is global when the whole brain is being affected. So it means every part of the body is affected. Usually people don't survive that time. You just die instantly or just after a few minutes. So any pathology or disease that you have as a result of the brain being affected, that you have a focal, either focal means maybe your hand, one hand or the two hands are not working normal, or you have a problem with your speech, or global, you have a neurological deficit that is all over your body. That's what it means. There is a vascular. Vascular means blood vessels. It's actually a function of two things, the brain and the blood vessels that give food to the brain. Food in terms of oxygen and also blood. You know, the blood carries glucose and other things to feed the brain. So once we have a problem with that, then we now term that this person has a stroke. Now, stroke can be classified basically into two types majorly. We have the ischemic stroke and we have the hemorrhagic stroke. Then we have a little percentage of stroke, which we term the cryptogenic stroke. The cryptogenic stroke is a type of stroke that is actually the cause is not known. Nobody knows where the cause is from, but the person is having some neurological deficit. Now, for ischemic stroke, there's usually compromise or there's usually blockage of blood supply to the brain as a result of either there is a clot of blood that is blocking a small blood vessel to reach there, or you know, there's this thing we call thrombotic activities, where the blood vessels, there's a lot of collection of clot and it's long and it occludes the supply of blood to that area of the brain. Now, the second one is hemorrhagic. Hemorrhagic, it means the blood vessels are there in the brain, they have rented or they have what we call open up, and blood is now, you know, covered or gathered in a particular area of the brain or in the entire brain. So that is hemorrhagic. Now, majority of the stroke that we have within this country and even outside the country is actually the ischemic type. That's the one that the blood vessels is being blocked and blood supplies does not reach areas of the brain. And if it doesn't reach area, all you just need to do, just give it time. Any area of the body that does not have blood supply and oxygen, give it time. What it happens is there's going to be necrosis or what we call cell deaths around that area. So that is exactly what it is. While the hemorrhagic, like I said, is actually bleeding into the brain, maybe within the brain space or the space around the brain. You know, the brain has some covering. It has three covering. The first covering is what we call the pia mater. The second covering is what we call the arachnoid matter. Then the third covering is what we call the dura mater. Sometimes you may not even, you have the brain, you have the bleeding within the substance of the brain. Sometimes you just have after the first layer of the covering. So all these things. Now, if you have after the second layer is what we call subarachnoid hemorrhage. It is under the second layer or second covering of the brain. And we call that subarachnoid hemorrhage. It's also a common type of the hemorrhagic type of stroke. Now, this picture that I'm displaying here is actually trying to show us the vasculature or the blood vessels that supplies the whole brain of any individual. So all of us have this kind of connection of blood vessel in our brains. Now, we call that the circle of Willis. It is very important for us to understand this. Anywhere or any part that the blood of vessels is affected is either rent or is occluded. We will have any of the type of stroke. If it's occluded, we call that ischemic. If it's renting or there is leaking of that particular part, we now call it hemorrhagic stroke. Now, basically, there are three types of them that are usually very commonly affected. We have the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. They are all arteries that supply areas of the brain. Now, stroke is the third leading cause of death in the Western world and the second in the whole world entirely. Now, there are other types of death. Another very common one is ischemic heart disease. That is another equivalent of problem that occurs in the heart, similar to that of stroke. You understand, is the first cause, then the second one is stroke. In Africa, it accounts for 4 to 9% of death and 6.5 to 41% of neurological admission in the hospital. So if you come to the hospital and you're there, 6 to 41% of any neurological admissions, it means anything that has to do with the brain or nerve, it is as a result of that stroke. And one very bad thing about this is that the incidence rises with age. As one is getting old, then it's more likely that person develop that stroke. That's what it means. Now, it is more picking the occurrence at the 8 decades, people that are octogenarians, that are in their 80s, in males, and people that are in their 70s in females. Those are the times that easily you have discovered that this strokes comes easily. Now, if you have those risk factors, you become prone. I'm not trying to say that anybody that have reached that age must develop stroke. No. That is why we're talking about aging gracefully, where WHO is talking about healthy aging and all of that. There are some things that you need to put in place that you age healthily. People live up to 100 plus years and they're still agile without stroke or any other thing. Now in Nigeria, mortality, which means death, mortality rates is very, very high with a range of 21 to 45%. It is worthy of note that most of the death patients in Nigeria studies died within the acute phase. The acute phase is the first 48 hours of that stroke occurring. So most of the times, because majority of times people don't present to the hospital, people don't know what to even do, people don't even know what is happening to them. A lot of people, we're still backward in this part of the world. They keep on saying it's a spiritual attack, this one is doing this thing to me, or this one have started this and that. Before you start doing that argument and we are beginning to talk about coming to hospital, that person is already gone. Now, in older age, that is the older persons, of course, just to define who an elder is anybody that is chronological age 60 years and above. That is the definition by United Nations, or by the World Health Organization. Anybody that is 65 years of age or older is termed as an elder person. So older age has been shown to be a strong predictor of mortality in stroke. It means that if you have this entity we call stroke in the young, a stroke that occur in people that are less than 40 years. Now, sometimes most of them will survive that because they still have their reserve or energy and other organs intact. But if it occurring in the elderly persons, it comes, most of the times, it takes away the life of the older persons because of probably the reserves are depleted, physiological decline, and all of that. Now, stroke prevalence was found to be high and common among men and the elderly population. Look at how I highlighted the elderly population in red. You understand? These are studies that have been done in Nigeria, in South Nigeria here. And they found majority of the people that die about stroke, elderly population. And the most predisposing factor to that stroke is hypertension. It means when you have a raise in the pressure in your blood vessels, you're more likely to develop that. (460 to 370 BC, where books have been written, where people are saying we have apoplexy that was defined to be struck down by a violence of paralysis. And people, of course, then they will not know that's what it is, but they will say people will just come down and they have paralysis. So that is it.
Can hear you clearly.
Yes, we can hear.
Okay. All right. Thank you. Sometimes we term it brain attack, so that the people would take it with all seriousness and to know the severity of that entity we're talking about, stroke. You understand? Now we can also have what we call transient ischemic attack. Now this is what people term commonly as mild stroke. You see somebody has a mouth that is deviated. After some time, the mouth becomes fine. Or somebody that has weakness, paralysis, partial, maybe in the morning to afternoon, then before evening, the person has resolved. So we call that transient ischemic attack. When the deficit resolve, or when this insult or the weakness that one has resolve within 24 hours, we now term that as transient ischemic attack. Now, there's also an entity that is called reversible ischemic neurological deficit. When this neurological deficit or the body weakness or all the problems that the symptoms that the person in question is exhibiting is greater than that 24 hours, but resolve within less than 3 weeks. You understand? 21 days. Once you have that, we now term the person to be having reversible ischemic neurological deficit. So that is it. Then, of course, when you have neurological deficit that is lasting greater than a month and all of that, we can now say, okay, fine, this person has a stroke, complete stroke. Now, what is the pathophysiology? Pathophysiology, like I earlier said, is actually how does this stroke come about? Now, central to it, there are three main things that happen, like I earlier talked. The first one is when you have arterial embolism. Embolism is when you have a blood clot from another area of the body, and that blood clot is moving in the blood vessels and moving in the blood vessels, then temporarily come to stick itself somewhere and prevent that blood supply to that area of the brain. We now call it an embolic stroke. Then when a lot of these clots come together and block a whole lot of blood vessels, maybe a 1 centimeter or 2 centimeters long, we now call it a thrombotic stroke because it has blocked all the blood vessel, the blood that is supposed to be, used by the area part of the brain. Then the last one is what we call the hemorrhagic stroke. That is a stroke, like I earlier said, where you have bleeding directly into the brain or between the space or covering of this brain. Now, the common type of the hemorrhagic stroke is what we call the intracerebral hemorrhage. That means within the substance of the brain, if you have hemorrhage or if you have bleeding around those, we call it intra. Then the other very common that occur in 5% of patients with stroke is the subarachnoid hemorrhage. Subarachnoid hemorrhage, I said, is actually a covering, the second covering of the brain. So below the second covering, you can have bleeding. That one has bad prognosis. Usually present with very severe headache. You see people tell what they call thunder clamping headache, the worst of headache that I've ever had in my life. And once they have that, if nothing is being done within a short period of time, it takes the life of the individuals. So this is just a diagram depicting a blood clot like I earlier talked about. This, you can see the blood vessels going right up to the brain. You can see the small tiny clots that have occluded the blood vessels. And that area that is whitish, that is within the brain, what do we call it? The brain of that individual in question is the area that is not supplied with blood. So if this person has stroke, for instance, because of maybe embolic stroke, because of clot, or thrombotic stroke, because of a lot of these small clots that have gathered. Now, it will occlude or prevent blood from reaching that area of the brain. And that white area of the brain is an area of ischemia, or what we call the area of where cells begin to die. And one bad thing with neurological cells is that they're irreversible. Once you have a nerve cell that is damaged, nerve cells, it means from the brain or within the spinal cord or within the nerves that are within the body. Once you have it, it is very, very difficult for you to get it back again. That is why people stay all through their life with the deficits of stroke, because you can never get that thing again. That is even the reason why we need to talk about it. We need to know about it more. We need to do something about this stroke, because once it comes, it has a lot of sequelae, and that sequelae is usually very detrimental to the carers of the elderly patients, to the elderly patient themselves. It has devastating effect to the family. It has devastating effect to the community, and that is why we need to talk about that. Now, what are the risk factors? We have a lot of risk factors. Those are things that predisposes ones to have this stroke. As simply raised blood pressure, and anybody that has a blood pressure that is higher than 40 because of mercury, the systolic blood pressure, or you have a systolic blood pressure that's the down than or equals to 9 of mercury, we term that as hypertensive. Of course, there's some modifications of where you can increase it to 150 for the elderly patients due to some studies, and you begin treatment when they are 150, when the systolic blood pressure 150. But most of the time, like I do for my patients, why would I wait till that time? If I have other people that have multiple risk factors, even at 140, I begin to treat, because when the stroke will come, it doesn't knock at the door. It comes like our mom says, a silent killer. It comes gradually, and before you know, it takes the life of that person. The second risk factor is people that have diabetes mellitus. In diabetes mellitus is a disease that have problems with the sugar control system, or the glucose control system of the body, where the glucose becomes high and high and high, all it does is that it occludes this blood vessel. And like I say, the problem of stroke is brain and the blood vessels that supply this brain. So that's what it is. You could see boldly there, age is also a risk factor. Anybody that is age 65 and above, it's at more risk of developing stroke than any other person. Any person that has what I earlier termed as TIA. TIA means transient ischemic attack, or what we call mild stroke. The fact that you have mild stroke and it's resolved, it is a strong risk factor for you to have a full-blown stroke in future. So you must do all it takes to prevent these things from happening again. You will be lucky the first time it comes and it's resolved within maybe less than 24 hours. It's a warning sign that you need to do a lot of things about this risk factor. If not, the second time it's coming is going to be devastating. Now, the next one is polycythemia. Polycythemia means when you have a lot of red blood cells, a lot in your body, above maybe 45 for male and close to 50 and all of that. Now, percent. If you have blood vessels, if you have a lot of blood vessels, you are prone to developing this stroke because it makes your blood thicker. And you know, when there's thickness in blood, the movement becomes slower. So I forgot to mention the earlier thing. Stroke is actually a function of three things. The third one is, one I said is the blocking. Second one is bleeding because of renting of this blood vessel. The third one, if you have sluggish movement of blood vessels because of the viscosity or because of the thickness of blood, that can also cause stroke because the oxygen will not move to the brain as usual, thereby delaying oxygen supply, and one can have stroke. Sickle cell disease, people with sickle cell anemia can have that. A lot of times it is a major cause of stroke in the young. Like I said, stroke in the young is the type of stroke that occur in people that are less than 40 years old. People that use oral system, for people that are probably women that are menopause and all of that, you have a risk of developing stroke if you keep on using that. Other risk factors will include carotid stenosis. Carotid stenosis means there's a major blood vessel they call carotid artery, where if you have narrowing in any way, this narrowing will make blood not to flow to the brain. It can also be a risk factor. Other things will include heart diseases such as heart failure, atrial fibrillation. Atrial fibrillation means the electrical activities of the heart is not moving the way it is. The pumping of the heart is not the way it is. So there's delays and blood tend to stay in the heart for some time before it's being pumped. And you know, once it stays for time, it can clot. And this clot has sent into the brain before you know it will close the blood vessel, and one has that. There's something they call malignant trophoblastic disease. They're actually diseases of women as a result of, you say, mild form of cancer that occur within the womb of woman. People that is also a risk factor for stroke. We should know that. Now, hyperlipidemia, it means when you have cholesterol level or lipid level that is very high in your body, you tend to be. Obese people, people that have BMIs, body mass index, greater than or equals to 30 are at risk. So the better we have the normal weights and normal BMI, the better for us, because it also serves as a risk factor for this stroke. So lifestyle means lifestyle that you're inactive all the time, like people, for instance, that are workers, you wake up in bed, you're in AC, the next time you enter your car, you're in AC, you've not stepped, you've not had any steps, you are in a place of work, you're in AC, seated, you eat a lot of junks, you're seated, and you don't exercise your body. And always eating, you're adding more weight, and you're not, dissipating this energy that you're accumulating. That can lead to stroke also. Hypertension means lower blood pressure. I talked about higher blood pressure the first time. Lower blood pressure is also a risk factor. When this blood pressure are very low, so that the pressure that in the vessels cannot be sufficient enough to supply blood vessels, to supply the brain with oxygen and blood, then there's a problem also. Dehydration, where you have waters that within your body that is depleted, that will also make the viscosity of the blood very thin, that it's not going to supply oxygen to the brain. That can also be a risk factor. Congestive cardiac failure, severe anemia, low socioeconomic status, the black race. Our black race is a risk factor to developing. So it is found out that through studies and research that Black men come down with stroke more than the white people. So we need to do a lot to prevent that. Male sex is also a risk factor too. So we found out that men are the ones prone to have stroke compared to women, probably because of how stressed men are. They are involved in trying to take care of the family. All the burdens of the family is on them and all of that. So that could be positive family history. It means if ones have parents or grandparents that have been affected by stroke, it means you're more likely to have that also. Other things with hyperuricemia. Hyperuricemia, when you have your uric acid level that is very, very high, that can also lead to stroke. Now we have other risk factors such as neoplasm. Neoplasm means swellings within the brain. Just swelling, it could be benign, which is non-cancerous. Then it could also be malignant, which is cancerous. Now, if you have the swellings within the brain, and once you have a swelling, there's usually a blood supply to that swelling in the body. So the blood pool so that it will make the swelling to keep on growing. Sometimes you may have blood vessels within those swellings and they can rent or they can be occluded. And before you know, you begin to have strokes with that. Recreational drugs, we have discovered that people that abuse substances, such as cocaine, amphetamine, and all of that, they are more likely to develop this stroke also. This usually type of stroke that they develop is the embolic type of stroke, the ones that embolus are being thrown into the blood vessels and they prevent the blood vessels from supplying blood to any part of the body. HIV is also a risk factor. Hyperhomocystinemia is actually a condition where you have one of the deficiency of an enzyme in the body. That is also a risk factor. That is why if you have deficiency in folic acid, it is predisposed ones to heart. One of the preventive things is, we'll be talking about later, is you take a lot of fruits and vegetables that are rich in some of those folic acid and other minerals that will help you not to develop that kind of stroke. Now, this is thrombotic stroke that I earlier talked about. I've done a lot of explanation on it. Usually that's when you have complete occlusion of the blood vessels. It presents with headache. No, headache is not usually a significant feature here. Most times is you have signs of raised intracranial pressure, where you have people that can be having vomiting when they have this raised intracranial pressure. You have impairment in sensorium, where you see persons, they are not fully conscious or they are semi-conscious. They talk to you irrationally and they have delirium. Delirium means acute confusional state. It's one of the features that is very commonly exhibited in patients that are elders that are also developing that stroke. Embolic stroke, I talked a lot about it. Let me skip this. Subarachnoid hemorrhage, this is the ones I talked about, bleeding within the covering, under the covering of the brains. It has a very bad prognosis in this type because it can kill one just immediately as it's occurring. And one very bad thing is, we live in a place where our hospitals are not equipped. In developed world, you have stroke units. And there's something they call the golden rule. If one is noticed to have stroke, all you need to do, you just need 60 minutes before you get to the stroke unit, 1 hour. And we have a lot of stroke survivors in the Western world because they tend to obey that golden rules. They have emergency health services. They have, everything in place. Where somebody is having stroke, it can be taken. You call 119 and they fly you to the stroke unit and a helicopter will come. But it is not the same here in our country. Most of the time, we will stay there and start debating whether that person has even hurt somebody and somebody is trying to attack him. And look, before you know, that person is gone already. Now, in this subarachnoid hemorrhage, it has some symptoms. Most times it presents with seizures. Seizures means convulsion. You see somebody just slump down and some part of the bodies are moving. Ptosis. Ptosis means drooping of the eyelids. You just see the eyelids, instead of looking up, it's down. You can have that. You have dysphagia. Dysphagia, you have problem with speech. That's what dysphagia means. Problem with speech, either inability to speak out or even inability to even comprehend what one is saying. You understand? All these are terms as dysphagia. I talked about a lot of this. I think I'm just going to do intracranial hemorrhages. These are bleeding directly into the substance of the brain. You understand? It leads to elevation of of the pressure within the brain, because of course, the brain is enclosed by the skull, and the skull is actually a hard thing, and you're bleeding inside it. There's going to be a point that the pressure will be very high on the brain, and the person will start exhibiting signs of raised intracranial pressure, such as vomiting excessively, projectile vomiting, such as loss of consciousness, and all of that. So those are the features. Now, what are the symptoms and signs of stroke? We'll briefly go through that and we move on. Now, first, there's sudden numbness or weakness in the face. You see somebody's face that is straight, then one side is going down. Of course, that may be a sign of stroke. Arm or legs, especially, or one side of the body where we have what we term hemiplasia or hemiparesis. Hemiplasia means weak paralysis completely. The powers with is reserved, or the person can use to some certain extent the side of the body that is affected. Sudden confusional states, which is common in the elderly, or what we call delirium. You know, speaking or understanding speech is also, like I earlier talked about. Sudden problems seeing either one eye or both eye. I've seen patients that come down with stroke. The only symptom they are presenting was blindness. Sometimes one eye closed completely. Can you see with this eye? They will say, no, doctor, I cannot see. Can you see with the two eyes? Somebody that is seeing then suddenly becomes blind. There are areas, like I said, every area in the body is represented in the brain. Now, for the people that comes out with direct blindness, it's because probably the bleeding or the occlusion or the deficit that is occurring in the brain is happening in where the area that is controlling vision of the body. So once you have that, that is the symptom that once manifests. Sudden dizziness, loss of balance and coordination, troubling walking, sudden severe headache with no cause, can be a sign. Other danger signs may occur, which include double vision, drowsiness, nausea, and vomiting. All this can be signs of that. Now, for people that have intracerebral hemorrhage, bleeding into it, you may discover in that patient, check their BP, the BP is high. Second thing, they may have fever. They may have nuchal rigidity. Nuchal rigidity means neck stiffness. You can't move your neck freely. That is it. We have hyoid retinal hemorrhage. If you do a fundoscopy is when you use the ophthalmoscope. There's an instrument we use in the hospital, ophthalmoscope, to check the eye. And within the eye, if you check the back of the eye, you see what we call the retina. Retina is one part of the eye that is helping for someone to see. You will see retinal hemorrhages around that area. Of course, anisocoria means pupils, the apple of the eye, becomes different in size. Ideally, everybody's supposed to have around, about 2 millimeters of the pupils of everyone. Once you have one is dilated, maybe about 5 millimeters, and the other one is 2 millimeters, or it's even less than the 2 millimeters that I talk of, then we call that anisocoria. Then focal neurological deficit, like I earlier said, is any weakness in any part of the body. This is just for the sake of remembering, we term that act fast as the first sign of stroke. Now, FAST, the first one is facial weakness, second one is arm weakness, third is speech difficulties, time is the brain. Call 911. For us, you need to rush to the hospital in our environment. You need to alert somebody that takes care of whoever that is in concern so that he can be salvaged as much as he can. If not, that person is in a state of imminent death or can even die at any time. Now, I talked a lot of different types of stroke. We talk about cerebral infarct. The onset of this type of stroke is stepwise. It's actually progressive. It starts with blindness, then cranial nerve deficit, then weakness, then the legs is affected. That gradual progression, that's what happens in cerebral infarct. Intracerebral hemorrhage, you have raised intracranial pressure. Coma is usually, people can present with coma. All they knew, the normal healthy person falls and he lost his consciousness and he remains there. Sometimes you can even see people in coma for 3 weeks in the hospital, 2 weeks because of this stroke. Some come out of it, some will not be lucky to come out of it. They will just zoom into death. Now, I lost somebody from my village last week. They were calling me. She was normal. She had hypertension. I used to know her. And most of the times I see her in the village, I say, Auntie, you need to be taking your antihypertensive. Sometimes she say, she used to forget that. The next time they call me, this woman slump at home. Nobody knows what. I had to tell them they should rush her to the hospital. She stayed for 2 days in the hospital. And after that, she could not regain her consciousness. She has to go. So that is why we must take this with all seriousness. Are they low or are they high? If you have people that have low platelet, then they are more likely to bleed. So that bleeding can even occur at the brain. You understand? So chest X-ray, like I said, heart diseases can be gotten or can be seen through chest X-rays. And that is the reason why we are doing chest X-ray, so that we exclude these heart diseases, which are risk factors to developing stroke. Blood sugar, very important, because I said one of the risk factors of developing stroke is diabetes mellitus. Lipid profile, we want to know the level of cholesterol in the body. Urinalysis, we want to know, from the urine, whether one has glucose, which is tending towards having diabetes mellitus and the rest of them. Central to the investigation is what we call neuroimaging. Very, very important. We have the CT scan, CT scan means computer tomographic scan. We have the MRI, magnetic image resonance imaging. That's MRI. Those are big, larger, would like to say, X-rays, where the areas of the brains are being seen, and are being the areas that are affected are located, and immediate measures are being done to prevent this further deterioration of that. ECG, you want to know the electrical activities of the heart. You want to know how the heart is also functioning so that one cannot develop that stroke. Other investigation, mostly are the ones that you do in subarachnoid hemorrhage, would include full blood count, like I say, the neuroimaging also. In here, if you are suspecting subarachnoid hemorrhage that is bleeding within or after the second covering or below the second covering of the brain, like an area top, CT scan is better than MRI. You understand? So that is it. You can also do a lumbar puncture. There's something they call CSF. CSF is cerebrospinal fluid that are located within the brain and spinal cord. So if you have bleeding within this CSF, if you do a lumbar puncture is a procedure where this water or the CSF is being tapped from the back. Usually we do it for children, but in adults also can be done. You see it bloody, or it will have what we call xanthochromia, a yellowish discoloration like that. Once you do it and you see that, then one is suspecting to be having subarachnoid hemorrhage. There's something they call angiography. Angiography, it is a type of test where the lining or the blood vessels within the brain is being outlined because of some substance that have been injected into the blood vessels to outline this substance. Anywhere where you see there's no continuation of blood flow, you know that that's exactly where the stroke is happening. And it's usually give you, for instance, I will talk about the management of stroke later. Some will be lucky to have surgeries. You know exactly if you're opening up the head or the brain of that person, this is exactly where you're going to. That's where the problem is, and it will direct you to do the surgery appropriately. We all talked about ECG the other time. We talk about this, all of that. So these are this. Now, for senior citizens with stroke is among the top leading cause of death and disability, and it reduces the quality of life. Disability in the sense that one has weakness or has speech problem. You see a very agile elderly person, and suddenly he cannot walk, suddenly he cannot talk, suddenly he cannot eat, or he cannot carry out the activities of daily living, dressing, eating, and all of that. Then there's a problem. It comes with a lot of challenges, including depression, including neurocognitive depletions, and the rest of the like of them. Elderly patients are at higher risk of mortality, poorer functional outcome, prolonged hospital stay, and institutionalization. Now, what do I mean by that? Once, like I earlier talked, once a person is an elder person is having stroke, then it is more likely that this stroke will have more effect on that person than the person that is less than 60 years of age. And the mortality, which is death, is more likely. Poorer functional outcome, the functioning, for you to get that person back to how it used to function is very difficult. And they are the ones that stay longer in hospital before they recover, if eventually they even recover. Then they are the ones that we take to nursing homes. You understand? Nursing homes to be taken care of. I'm going to talk about that now. We don't constantly do that in our environment, simply because maybe we say, we have people at home to take care of it. Sometimes we don't even see the burdens or the burnout of the primary caregivers of these stroke victims. You understand? We now keep them at home and the whole family is in trouble and the rest of them. Most of the times, if we have the means, keeping them in nursing homes are the best to be taken care of. After the acute phase have passed, the doctors have seen and have stabilized the patient. Now for rehabilitation, it is better being done either through home care or being taken to the institutions. Now, a report says that the risks of falling and falling-related injuries were higher in stroke elders. Of course, people that have strokes usually have one weakness in their part of the body. You see the weakness, they have gait abnormalities, they are walking, one side is going down, the other one is that. So in that categories of patient, you're more likely to develop falls in the elderly. And falls are actually major problems of the elder patient. A child can fall and nothing happens, it's fine. People will be laughing. But if an elder falls, it comes with hip fractures, dislocations, a lot of issues. So as geriatricians or people, stakeholders in the aging, we don't like strokes completely, and falls, I mean. And like I said, stroke is a risk factor for falls. Risk factors associated with increased falls in stroke survivors include poor general health, time from stroke, psychiatric problems, urinary incontinence. One of the features that we develop when one has stroke, you can have urinary incontinence. And people feel very, more than the elderly, they feel very shy. And how can I not be, I'm continent, then suddenly I'm beginning to behave like a baby. They want to go and ease themselves or something. And before you know, they are down on the ground and it affects their problem. Now, post-stroke cognitive impairment is also a common thing where you have language problem, fatigue, depression, and apathy. Depression is associated with stroke a lot of time. People come to the hospital and just go away, and some, even the physicians, the nurses, and the stakeholders, leave those issues about. And you see people dying up with those things. And our management should be holistic, considering every aspect of the elder and should be managed. People can have cognitive impairment. It means dementia. Dementia, you have problem with memories. Once you have dementia, you have stroke, you have risk factors to developing those dementias. It is a major risk. In short, sometimes some studies have even said they come concurrently. If you're having stroke, it comes with the dementia. You understand? There's a type of dementia that is called vascular dementia, and that type of dementia, go pari passu with stroke. Bladder and bowel dysfunction, e.g. urinary incontinence and constipation, is very common among people that have stroke in the elderly. Pressure sores, because most of the time they are confined in bed, they are bedridden, they cannot move from one. And once you stay long in one point, before you know, you begin to have what we call bed sores or pressure sores. And usually it's a bad prognostic features. Once one starts having that, it means the grave is moving closer to that individual. So, and it is very common in people that are age 60 and above. Approach to management. Usually what we do, if patients are unconscious or are in coma, we follow the ABC of resuscitation. A stands for airway. We try to clear the airway to ensure that they are breathing. B, we want to take care of their breathing. If they are not breathing, they need oxygen. We need to give them oxygen. C means circulation. We need to be sure the circulation is the BP very high. If the BP low, we should address those things. Oxygen is something very vital. Now, there is this thing, once people are coming down with stroke and maybe due to hypertension, the blood pressure is high. We want to bring it down as much as possible. People have brought down this blood pressure and the next thing is the patient is gone. It has a limit in which how you can, bring down this blood pressure, you must calculate what we call the mean arterial blood pressure. There's a formula, a specific formula for calculation. Once you have mean arterial blood pressure that is greater than 140 in the hospital, or you have a BP of 185 over 110, then you gradually reduce this blood pressure to come to a considerable level like 160 and 110 and just leave it there. Now, by the time you have somebody who have 180 over 110 and you're bringing it to 120, 90, the next time you're coming, the patient is no alive. We can put tubes, NG tubes, because most of the time they cannot feed, they're unconscious, you understand. We can give something they call mannitol. Mannitol, they usually have what we call cerebral edema, collection of water because of the insult and injury that happens within the brain. So we want to get this water as much as possible out. We give them osmotic diuretics like mannitol, and this mannitol comes out and bring out this fluid to reduce the pressure within the brain. Thrombotics are actually thrombolytics, are things that will break those clots that I talked about. Some injections can be given to break down those clots, and it should be done within 3 to 5 hours when this thing occurs. Most of the times we don't present before that time. Aspirin or clopidogrel should be part of the things that are given there. Low molecular weight heparin, all these things are anticoagulant to make that. Now, in the mid to long-term monitor for and manage for stroke depression, like I talked, a lot of them are depressed. We must do that. And we may need to see a speech therapies, we need to occupational therapies, the physiotherapies, all this. To manage stroke is actually a multidisciplinary approach, is it? Doctors alone cannot, because if the doctors usually take care of the acute phase, but most of other phase, other paramedics come into play, you understand? For nursing care, the nurses that are there for home-based care, the nurses or even the doctors are there, for speech problem, we have the speech therapies, the occupational therapies and all of that. We need to talk about walking aids and prosthesis. Sometimes they cannot even walk, and you need to give them all these walking aids to enable them get back to their feet as much as they can. If the person is, for instance, having embolic stroke, and one of the features is they present with seizures, you can give an anticonvulsant, anti-seizures, medications that will prevent further seizures. What you need to do is to tackle the predisposing factor. I mentioned whole lot. If it's smoking, the person should stop smoking. If it's alcohol, he should stop. If the weight is overweight or obese, you need to reduce his weight and all of that. The treatment usually, most times, like I said, the one that the soft arachnoid hemorrhage comes out with bad prognosis, and the bad prognosis, it can lead to death. So most of the times we admit this patient in intensive care units where you give them the maximum of. So that you monitor their vital. Like I said, blood pressures should be maintained within a certain level. There is something called aneurysm. Aneurysm is when you have abnormal dilatation of the blood vessels. Once you have abnormal dilatation of the blood vessels, it means the blood walls of the blood vessel becomes weak, and it can rent at any time. So these aneurysms can be corrected through surgeries and other means. You use endovascular coils to remove blood clots. This is why the reddish things within the blood vessel are actually clots of blood. So they pass out some wires and coils to remove them. Those things are usually not done in this part of the world. They are done in Western world where all these facilities are there. Most of these things, I think I talked about it. There's a place for surgery. We need to maintain bed rest within the 24 hours. It's very, very important. We need to avoid strenuous exercise. Most of the times, the stroke patient present with ulcers, peptic ulcers, as a result of the stress they are going through. So you must be mindful of giving them anti-ulcers, just like antacids, to try to prevent furthermore of these ulcers. Now, there's a place for ongoing home care and treatment, people that is home-based care. Nursing home care, very important to reduce the burdens of primary caregivers to the family of victims with stroke. Now, this is a picture of a nursing home where this patient has stroke and she's getting back her life back, in the nursing home. Nursing homes are very, very good places where stroke victims can, because it takes a lot of burdens from the primary caregivers. Now, prevention, a lot of prevention, briefly go into it. Sorry, we are going to finish very, very soon. I'm trying to tidy up. Primary prevention, what we need to do is to remove those risk factors I earlier talked about. Hypertension, we should control it as much as possible to bring down blood pressure. Discourage smoking and alcohol ingestion. We should control the blood sugar level. Maintenance of normal weight so that one will not be regular exercise. At least one should be active 3 to at least most days of the week, at least for 30 to 45 minutes, one should be active. The exercise should be done based on the age of the person, mostly of the elder patient. Of course, you don't expect them to go into strenuous activities, but they should exercise regularly. Lifestyle changes has to do with the method of or the food they consume, or how sedentary their lifestyle is. All this should be modified. Foods such as that are vegetable and fruits should be bulk of the food that the elderly takes, or even people that are approaching that age, because studies have shown that it has a lot of advantage of preventing ones from having hypertension and from hypertension and even stroke, you understand? So these are some of these measures. Secondary preventions, people that have TIAs, there are a lot of things. You must give them aspirin. Like I said, TIAs are mild stroke. Clopidogrel should be taken every day. This is very, very, very important. For people that have dyslipidemia or they have problem with cholesterol, they should be taken care of with medications to lower their lipid level or cholesterol level. Vitamins B12, B6, and folic acid should be given, to take care of hyperchromocysteinemia that I earlier talked about. Now, when was the last time you checked your BP? Checking BP is as vital as preventing stroke itself. So we must check our blood pressure on a regular basis because, like I earlier said, studies have shown that majority of the times of the cause of stroke within our environment is as a result of raised BP. Thank you for your time. It's a long presentation, but I appreciate the time and all of that we have. Thank you.
Oh, wow. Dr. Kubet, I think you should give us a certificate as doctors now, because we have all the information, at least a certificate for one particular side of medicine.
Thank you.
I demand a certificate, doctor. I demand it. I can't have all this knowledge for nothing.
Thank you. I'll graciously give it to you, ma'am.
Thank you so much. This is so detailed that I can't even begin to run through what you have said. But what my immediate take home in this whole thing is that we should have holistic management of our health from time to time. And that stroke can be managed, but it doesn't need only the doctor to manage it, even home care and people around us and so on and so forth. And then you are advising that everybody should check their BP. I didn't check mine this morning, but everybody should check their blood pressure and should make sure it is controlled. And for you to be able to remain healthy, you need to maintain your weight, regular exercises, regular checkup, lifetime changes or lifestyle changes, and then make sure you are moving. In fact, there is a movement now that is encouraging everybody to take 10,000 steps in a day. And to be able to, I personally would like to sell this to anyone that is out there, to be able to ensure that you're taking these steps, wear very comfortable shoes. I have converted or gone back to wearing canvas all the time so I can take as much steps in the day as possible, especially if you are busy and you find yourself in that place where you can't take out 1 hour, 30 minutes for your exercise, you can do it on the go. And that is by making sure you're wearing comfortable walking shoes. Even though it's not so fashionable, just do it for your health. And then you also have to eat proper food, take a lot of vegetables. This seems to be reoccurring in all our medical webinars. Take a lot of vegetables, and then a lot of vitamin-giving food. Doctor, I'm so grateful that you made out this time. I know how busy you are, and we're grateful to have. At this point, I want to go to the chat room and see what we have there. Please, once again, I would like us to register in the chat room our phone numbers, our organizations, so that we can reach out to you from time to time. Somebody is here, Sunny Guardian newspapers to everyone. He's saying, please, I need your slides to write my story from Sunny Guardian newspapers email. He has his email there. So we will get you the slides, of course. Do try and mention Dr. Kumbet, as you mentioned, the COSROPIN. Everyone is saying, thank you so much, Doctor. I told you, you must give us a certificate. We're not letting you go without a certificate. Mass Care Home, it's saying to everyone here, Busola is here. Then we have Omishore. Thank you for this. This is really educative. Ambassador Dr. Tobechukwu Princess is saying, I'm blessed being here. I really learned a lot. Thank you so much. I'm highly hypertensive. The Lord will heal you. God bless you, Doctor, for this presentation. And that is coming from Miriam Akitola. Waneka Okolo is saying, thank you, COSROPIN Secretariat, for this. I am impressed that Chinenye always calls up to remind members of oncoming webinars and meetings. Quite recommendable indeed. Thank you. Yes, she does call everybody to try and make the webinars. And even then, they still don't make it. We just pray that, we are advising that we let our members post these things in your members on your WhatsApp. Let's have quite a number here. The number today is not so impressive, but we still thank God for the number of people. Professor Fatai Adeshino Badru is presentation is illuminating, but too technical for people who are not on terms. All right, so too technical. Giving us their phone number. Mary Rosanna is saying, thank you, Doctor. I came late, but thank you once again. So we have Chidima Vivian saying, thank you so much, Doctor. Oh, I was late. Please don't come late next time. We appreciate your coming, but we'd like to have you in as early as possible. Ambassador Dr. Wechukwu is saying, liberate the women initiative. Okay, that's his initiative. Princess, that's her initiative. So we have Professor Fatai Adeshino. The contact is there. We have Chidima Vivian again saying good morning to everyone. Her organization is Praise Home Care Services, Lagos. Wow, nice. Then we have Ibrahim Abdul Karim to everyone saying, colleagues, I joined late, but I appreciate the efforts on enlightenment about the silent killer ailment. Okay, so we have from Chinyere Eze, the Assistant Secretary of the Coalition of Societies for the Rights of Older Persons. Since you're in the house, you will take the vote of thanks. I say very informative, thank you. And we have to everyone His contact is there. Dr. Adekule contact is there. Certificate of participation could be given to participants. All right, we'll look into that sometime. Thank you very much. That's coming from Professor Fatai Adishina. People are having network problem. We have some interference. Mr. George, can you look into that interference? All right, 60 slides, very rich, inspiring, and loaded. Yes, I agree with you, my dear Prof. And thank you, Reverend Victoria, always a fantastic anchor. Thank you so much for your compliments. That's one Neko Kolo. Thank you so much. God bless you. So we have other people here. We want to say we see you, Otule Chris. Thank you for your comments. Thanks a million for the support all the time, coming again from Mass Care Home. All right, I think, what are the common forms of treatment? Now we have a question from Professor Adeshina. He's saying, what are the common forms of treatment for stroke patients to be taken by lay people? Doctor, are you there? What do you say to this question? It's the only question we have.
Okay. All right. I appreciate the questions. Now, I would like us to be more concerned about the prevention than even the treatment, because, like I said, stroke is not something that one would wish even the worst of his enemies to have, because it comes with a lot of consequence. Like I said, the end of the spectrum is even death. Now, but however, let me come down so that we understand each other, Prof. The most common of treatment, usually it could be treatment within the acute phase. That is acute phase when the stroke that is happening within the first 48 hours. That is the acute phase. Then there are other treatments that occur after that 48 hours. The ones that occur after that 48 hours are usually rehabilitative. You're trying to get that person back to life as much as possible. Most of the times we succeed in getting them as close as normal, but we don't usually get them to the back, such as physiotherapy, where you take movement of the limbs, you understand, where you move the arms to make them have to regain their powers, speech therapy. You're beginning to teach these victims that are affected how to talk again, because they usually have speech problem. So those are rehabilitative features. Those are the things that can be done in nursing home. For the immediate, most times, it depends on how this patient presents. Like I said, we have different forms of stroke. Like, for instance, you have somebody that has a lot of pressure on the brain substance. What you need to do, if we can do imaging modalities, we can do an X-ray, they call it CT scan, and you see where the image is. Immediate measures can be done. They can be operated to arrest this bleeding, to avoid it coming, is one of the treatments. Now, for the ones that cannot be operated, that's the infective type, some medications can be given. One of the medications is you're trying to give antiplatelets, anti-drugs that would make this blood not to clot. I talk about how blood lump together, blood cells, and block the blood vessels and prevent them from moving. So you're trying to break out these clots so that blood will now be flowing to those brain areas to get to reverse their walk back. Some of these, a little about some of those treatment that I earlier. I hope I didn't use medical jargons again more, Prof. Sir.
Oh. Thank you so much, Doctor.
Yes, sir.
Hear me? Thank you so much, Doctor. It's been an awesome time. It's been a great time. And I'm so glad you accepted this invitation. We are so grateful to all the wonderful professionals that make themselves available for our webinars, and more beyond 1 month. And so We are grateful when they agreed to come in. We're so very grateful. I would like to hand over to the secretary, assistant secretary. She's not available. Okay.
Question. My question is there, please.
Oh, all right. Prof, can we take your question?
On the chat box.
On the chat box. Okay, all right. We'll do so. Okay. All right, so we are coming from so many comments all of a sudden. Okay. Professor Day. Okay, your question has been answered, I hope, Professor. And then we have Yela to everyone saying, thank you, doctor, for this well-detailed lecture today. I have a good knowledge of what to tell the elderly at our next month's outreach. All right, I am a clinician, but the questions are, okay, coming from, okay, he actually asked that question. Prof actually asked that question for everybody to understand. Okay, Doctor, thanks very much for the enlightening presentation. Kindly give up
Can you help me reduce?
On taking 10,000 steps daily.
Victoria, can I make a comment, please?
Please.
Can I make a comment?
Can I just finish what I'm going through? I'll get to that. Thank you. All right, so Okolo says, Doctor, thank you very much for the enlightening presentation. Kindly give us your candid opinion on taking 10,000 steps daily. I do. 10,000 steps takes me about an hour and a half at brisk walking, and it doesn't quite with my limbs and my body in general. Doctor, you have to take that question. The three forms of prevention, primarily secondary and tertiary, resource-constrained communities like ours, where people pay from pockets. Okay, that's coming from Professor Fatai. Okay, right. Doctor, could you take that question on 10,000 steps?
Okay.
6,000 most of the time, but on today's I try to get to 10,000. So please answer her question. Thank you.
Okay. Now, there are actually research that have been done to help one to know whether you are active, whether you are living a sedentary lifestyle, you're inactive. Now, these are joined or are attached to number of steps one take per day. You understand? And sometimes, for those of us that don't know, we use the podometer. Podometer is actually a button, a small button, where you can attach your legs and it counts the number of steps. You can't be counting the number of your steps as you go, counting 1, 2, 3. Somebody will say that, what is wrong with that? So that's what you used. And this podometer, it counts your number of steps. Ideally, from any steps greater than 5,000, anything less than 5,000 steps per day, it is what we call the person is inactive. But once you reach 5,000 and above, we now say you are somehow active. If you're reaching about 7,000, you know, to let's say, maybe let's say greater than 12,500, that's when you say you're highly active if you want to lose weight. If you want to maintain weight, you take the steps from that 7,000 to about 10,000, it's fine. You're trying to maintain your weight, and it's also very, very healthy for the elder persons. And it is age-friendly in this case. I have to mention that. Like I said, the exercise that we're doing, it has to go with the age. Strenuous exercise can be very, 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 very problematic to the elderly patients. So it must be guided, it must be in order. That is why we even advocate for that steps, because steps is just steps. You're trying to walk, and it is one of the easiest form of exercise to do. I hope I've answered the question.
Okay, thank you. I guess I will give them. Evelyn to say something.
Thank you so
Good
much.
morning. Oh my God, there are two Evelyns on the floor. No problem.
Okay, I'm talking about Professor Onuigwe.
Right. Thank you very much, Victoria. And thank you, Doctor, for the brilliant talk you gave. I just wanted to make a comment about the question that was asked. What kind of treatment should the lay people give for stroke? And you have answered, but I think that we should lay more emphasis on prevention of the risk factors like the point. That is much more important. The lay person doesn't have to know the treatment per se of stroke, but if they're able to prevent the risk factors, then you have treated the stroke. Stroke won't come at all. And so, like you said, that involves making sure that you treat your hypertension, control your hypertension. Again, hypertension cannot be treated, can be controlled. Control it, see your doctor, keep to your appointments. If you are diabetic, make sure it's optimally controlled, and lose weight, maintain your ideal body weight, no smoking, no alcohol, keep active like you said. So the emphasis to me should be that we should emphasize that preventive measures should be put in place by everybody. Even if you think you are healthy, try and practice these preventive measures. That will help better so we can avoid the stroke completely on its own. Thank you very much.
Thank you so much, Prof. I'm grateful.
Why I talked about
Coordinator. I can see her on the floor and her hands are up. You could unmute and speak. You're welcome.
Good morning, everybody. Good morning, Madam Secretary. Thank you very much for this enlightenment this morning. But what I would just want to say concerning this is when the stroke happens, because there's actually an increase in this in recent times. And I would want to encourage everybody, if you're like 55 years and older, and you are retired, or 60 years and older, and you have somebody in the house, I always encourage people to have at least a companion in the house, whether a domestic staff or somebody that is living with you. We are now in the age of where anything can be accessed online. Please, when stroke happens, we don't have ambulance emergencies. We don't have all of that to come to us at the moment. Try and encourage each of your household member to learn about this. You can go on YouTube to check what you can do immediately so that it doesn't deteriorate faster before a doctor comes or before you get to the hospital. So I would encourage everybody here that if you know that you have 60 years older and above, staying alone, it's not advisable any longer. Have somebody to live in the house with them. And these people living in the house with them should be taught what to do immediately if they see any of those symptoms. Thank you.
Oh, awesome, very awesome. And we run my organization, Grace Nursing Care Center. It's a nursing home. We teach people to send their primary caregivers to come and learn some of these things, and even drivers to come and learn for CPR and so on, so that they can actually rescue their masters or madam on time. It's something that people should really take seriously, ensuring that their immediate or domestic servants are quite equipped in this area, especially if they are older, probably 60 years and above. Nowadays, 50 years and above. Yes, at this point, we want to say a very big thank you. I happen to have my president in the house, and okay, he's gonna. I would like to call on you, DG, the gerontologist. She happens to be a very dear coordinator for Lagos State. Could you just give us a quick? Thank you. Hello. Okay, it's like she's no longer on. I'll just say thank you to everyone that has made it here. God bless you. And please watch out for our next webinar. It's just in a few days' time. I think it's about a week's time. It's on Thursday, November, and it's going to be drug abuse in elderly. So please do watch out for it. Thank you very much for attending, and God bless you. Have a blessed day. Bye. Thanks.
Bye.
Bye.
Sonny, very much.
Thank you.